one of the changing paradigms in the treatment of EGFR mutant lung cancer is that there is increasing frequency, I think, by the clinical investigator to rebiopsy at disease progression, because there are different resistant mechanisms that we know about. Preferably, we would like to use a tumor-based biopsy, because then we can detect the small cell transformation, and we can maybe detect the MET and the RET fusions, the receptor tyrosine kinase fusions more accurately, and also tumor-based biopsy. You can always get to the resistant mechanism, whereas liquid biopsy, the disadvantage of liquid biopsy is that not all the tumors are shredded into the blood, so you may not be able to detect the resistant mutation. The advantage of liquid biopsy is that it collects all the resistant mechanisms from all the disease sites in the body, so it's an aggregate of what is happening in the body. Whereas the tissue-based biopsy or the tumor-based biopsy, you only biopsy the site that is progressing. So if there is another site in the body that is progressing, it may be a different mechanism and you may not be able to detect it with tumor-based. So there are both advantages and disadvantages. Ideally, liquid biopsy is probably the preferable choice to do because it's easy, it's just a blood draw, and they can usually, with the current commercially available liquid biopsy in the United States, most of the resistant mechanism can be detected, with the exception of small cell transformation, where you really need a tissue-based diagnosis. Although, if you pick up P53 mutations and RB mutations in a liquid biopsy, if they look for it, then there's also a good indication that there may be something is happening in the tumor and becoming a small cell transformation. So going forward, since we are now starting everybody on osimertinib for the frontline treatment of EGFR mutant non-small cell lung cancer, on disease progression, my preferred treatment is to biopsy the tissue. If it's easily accessible and it's not high risk to the patients, I would like to biopsy the actual tissue. But it's so easy to draw blood that I almost will do a liquid biopsy. And in most cases, if I can detect a resistant mechanism that I can recognize that has been published, that may be sufficient enough for me to tailor the subsequent treatment based on whether you see a resistant mechanism or not. For example, if we see a MET amplification, then we may consider adding crizotinib to osimertinib. Crizotinib is a very strong MET inhibitor. If we don't see any of these resistant mutations that I mentioned before, then I would tend to use chemotherapy. Whether I continue osimertinib or not depends on the patient. In most cases, I like to continue the osimertinib and add the chemotherapy, which is carboplatin and pemetrexed, because I like to continue to suppress the emergence of CNS metastasis, which I think osimertinib is very useful. In some cases, I would just take off the osimertinib and just start with chemotherapy for a few cycles to reduce the tumor burden, and then at the maximum chemo response, I will add back osimertinib.